Welcome everybody to Pediatric Grand Rounds. It's my great pleasure to introduce Dr. Robin Mackin. But before we move into introductions, I will just start with a land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So welcome everybody. I'm Dr. Anna Karvovska. I'm the Director of Faculty Development and Mentorship for the Department of Pediatrics. And it gives me great pleasure to introduce our speaker for this morning, Dr. Robin Mackin, who is a general pediatrician at London Children's Hospital and an assistant professor at Western University. She attended medical school at the University of Ottawa and found her passion for pediatrics here at CHEO. She went on to complete her pediatric training at McMaster University, including an academic fellowship year where she completed the Clinician Educator Diploma program through the Royal College. Her interest in coaching stems from her experience as an elite athlete. Dr. Mackin was a Division I student athlete and had the privilege of representing Canada at the 2008 Olympics. So without further ado, Dr. Mackin, welcome, and we look forward to hearing about coaching to competency.
Thanks so much, Anna. Good morning, everyone. It's my pleasure to be here this morning to talk about a topic that I find particularly interesting and hope to inspire some enthusiasm around it as well. As Anna mentioned, I actually did my medical school training in Ottawa, and so it's kind of neat to be back at the place that sort of showed me the experiences that helped me pursue a career in pediatrics. So very neat opportunity to be back here and speaking with you today. I've titled my talk today, Coaching to Competency. What does it mean for medical educators? So over the next 40 to 45 minutes, I'm hoping to actually try to touch on these 4 objectives, keeping in mind that there's still a lot of, I would say, difficulties with clarity with some of these topics. So by no means do I actually expect that by the time you leave this talk, you'll have a clear understanding of each of these items. But what I actually hope is an overarching sort of theme is to actually just provoke some thought, maybe even challenge some of these concepts of coaching, and hopefully facilitate some future dialogue so that we can actually think about, we have a really unique opportunity to adopt and implement coaching in a way that we really want to benefit the learners the way that we intended to. And so what my hope is that people actually think through some of these things to really decide, what is it that we need to do to make sure that as we start inheriting these coaching philosophies within our medical education, that we're actually getting a return on investment. And so the first thing we'll do is we'll kind of just define coaching and look at the literature and see how people have actually defined it and understand the relationship between coaching and feedback. We'll also look to compare and contrast some of the very commonly sort of interchangeable terms in medical education right now, most commonly being that mentor and coach relationship. We'll also look to explore some of the similarities, but also acknowledge that there's some pretty distinct cultural differences between coaching in sports, which for a lot of us is where we've understood coaching to be quite successful, and coaching in medicine. And then last but not least, as we go through, I'll hopefully be able to introduce some ideas and talk about some strategies that we can think about as we're trying to apply these principles to benefit our trainees. As far as the session goes, so I probably won't be able to keep up with the chat as we go through the talk, but my hope is that if something comes up that sort of causes a reaction or a comment, I hope that you will put it in the chat so that we can actually explore it a little bit later. And certainly please feel free to put questions there as we go along. We are going to try to use an anonymous polling tool throughout because, as you can imagine, on a virtual platform, you almost can never read the audience. So it'd be nice to get some your reactions as we go through. So before we begin, although Anna sort of already disclosed this, I do obviously have an extremely biased lens on the topic. And I think that's probably important to know when you're hearing someone talk about coaching. So I actually had the opportunity to represent Canada at the 2008 Beijing Olympics, but I also have experience both coaching teams and also doing some individual coaching outside of medicine. And I'm married to a coach. And so coaching conversations and coaching philosophies is not an uncommon topic at our dinner table. And so with that in mind, I obviously come to this topic with a lot of experiences, but very much not related to being within medicine. The other thing to keep in mind is that I did come from team sports. And I think the relationship and the nature of a coaching relationship in a team sport versus an individual sport is different. And I think that's something to keep in mind as well. So I first want you to think a little bit about your reactions to coaching. And so certainly if you came and signed in for a talk at 8:30 in the morning, it's probably not a topic that completely bores you. But is it a topic that maybe confuses you still? You know, we talk about coaching, it's gotten a lot of hype, but do we have a clear understanding of exactly what we intend or what we envision when we're talking about coaching? Perhaps as soon as you heard the topic, you did a little bit of an eye roll, or perhaps you've been banging your head against the wall, because every medical education conference you've gone to the last 4 years has had an overwhelming amount of coaching content. Or perhaps you have both hands in the air and you're very excited about the topic because it's something that means a lot to you, or you have some pretty optimistic expectations of what coaching is going to bring to medicine. And probably the fourth reaction that I haven't captured here is just pure skepticism. So the people that sort of are like, you know, it sounds great in theory, but really, how are we actually going to operationalize this to actually make sure that it works? And so as you think about that, I have to share that my own personal journey has probably hit all of these different reactions. When I was a resident, this is when coaching started to become part of the conversation, because CBME was coming. And so the Royal College was talking about, you know, adopting coaching within our programs. And I was ecstatic. As soon as I heard that coaching was coming, you know, my impression is that as an athlete, I very much appreciated that I would have hit a performance plateau had I not had coaches. There's no way that I would have gotten to the level that I did without having coaches that were sort of invested in my sort of growth and development. So when I heard that coaching was coming to medicine, my automatic expectation is that I was going to have something very similar. So instead of just naturally going through a system and sort of being reassured and making sure I was meeting expectations, I was looking forward to having someone who was actually sort of dedicated to helping me sort of meet my full potential and figure out what that actually looked like. But what actually happened is that, you know, in the midst of my residency, I kind of felt like I went from having an advisor the week before to all of a sudden sort of being relabeled as a coach. But I wasn't really sure, at least as a coachee, what was fundamentally different. And I think I had very unfair expectations, because now that obviously I've had a few years to think about this, it's not actually possible for me to have the same experiences as a coachee in sports in medicine. It's going to be different. It has to be different. But the key is exactly what do we envision so that people have fair and realistic expectations of what that's going to involve. And so that's actually why I've gotten into really trying to understand, you know, what does the literature say about coaching? For the people who sort of conceptualize this, what exactly did they expect? You know, what is the how-to? What are the skill sets that both coaches and coachees need to make sure that this relationship is successful? You know, how do we make sure that this is not a redundant role to all of the other roles that we already have in medicine? And so that's sort of why I've gotten to the point where I've really tried to understand what exactly we mean. And so before we kind of dive into coaching philosophies and some of the background, I actually want to share a little personal story with you. And so to do that, I have to take you back to July of 2007. And so this was in Brazil at the Pan American Championships. And we had just gotten back from the medal ceremony. And we were greeted by the famous Marnie McBean, who, as you know, is a very decorated Canadian Olympic rower. And she saw us and she said, you know, congratulations, you know, it's really exciting. You know, we're really proud of you. But I want you to think about something. All of the countries that are going to be at the Olympics in 1 year are going to be training to be 1 year better. My challenge to you is to figure out, how are you going to be 1.5 years better? And I sort of stopped and I paused and I looked around, and, you know, some of my teammates were right back to celebrating, but I was really struck by this comment. You know, what a novel idea. She was absolutely right. Everybody's going to be training hard over the next year to be a year better. So how was I actually going to be 1.5 years better? And so that obviously triggered the 1.5 year better plan, where I essentially sat down and thought about every aspect of my game, thought about the goals for myself, and then what outcomes would actually make me feel like I was at 1.5 years better by the time we got to the Olympics in August. And to be able to do that, I obviously couldn't do that on my own. I sat down with my coaches. They helped me refine my goals. They sometimes had to adjust my expectations. Other times they had to actually challenge me a bit more. And I think the key thing is to recognize that, you know, things never go as planned. So as much as I could map out what the next year was going to look like, it's likely that things were going to have bumps and curves along the way. And so a coach is really important in that aspect, because they can kind of stay grounded. They're able to see the big picture when you as an athlete sometimes can't see past the next pitch, or the next inning, or the next game. And so I think it's really important to recognize that, for us to actually be meeting these elite levels or being able to hit these performance sort of elite experiences, we really need coaches to be part of those processes. And so as I reflect on that moment and sort of how that experience was for me, I ask you, what is our educational vision for our learners? So I want you to think about that for a second. So if I had asked you, what do you actually think is our vision for our learners? How would you answer that question? And so I actually pick a quote to share with you, and this comes from a study where they actually looked at medical trainees who had backgrounds as either musicians and athletes. And they interviewed them, and one of the quotes that was shared by one of the participants, I thought speaks to this idea nicely. So the participant said, there's evident advantages in encouraging doctors to constantly improve, rather than to attain a predetermined level of generic competency. And I think this quote is interesting because it almost starts to help us consider, is there a difference between personal best and competency? And as people who are training our medical learners, should we actually be striving for one or the other? Similarly, I challenge you with the question of whether or not we should all be aiming for the same finish line. I think that we all acknowledge and accept the fact that coming into any sort of major transition within our medical education journey, we all sort of have staggered starts, and that's okay. But should we really be actually looking for everyone to finish at the same finish line? Some would argue yes. And I would argue, well, perhaps we should actually be pushing for personal best or helping people realize what their full potential is. When we think about our entrustment scales, there's probably more than just a level 5. Not all the time. Sometimes a level 5 is exactly where I want to be. And sometimes there's actually room to be beyond a level 5. And so I ask you, should we be looking to actually be pushing people to their sort of personal potential? And another quote to share with you that highlights this idea comes from that same study. The participant said, clinicians often speak of competency. This has connotations of adequacy, whereas musicians, they speak of the even better performance and this constant need to push towards their personal best. So I think this rolls out the red carpet for us to obviously think about competency-based medical education, or CBME. When I was a trainee and CBME was being talked about, I had this misperception that actually CBME was coming because we were going to make sure that our trainees didn't graduate incompetent. That was kind of how I understood it. And then I joined the medical education community and realized that's actually not at all what they were thinking when they sort of came up with CBME. And the idea is actually that we in our traditional systems, for the most part, can identify learners who are either having difficulties or aren't meeting expectations. And it's usually those learners that get the most individualized attention. But as we shift towards a competency-based medical education system, we're actually looking to individualize learning for all learners. So this idea that we're actually dedicating and recognizing that it's not just learners that are having a little bit of difficulties that should benefit from some extra attention. It's that every learner probably deserves that. And so when we look at this framework that was shared by the Royal College, you can see that the resident learning is at the center. And then they've proposed 2 different coaching frameworks. So one is coaching in the moment. And we know that coaching in the moment is those daily interactions with your clinical supervisor or your preceptor, where you have the opportunity to sort of talk about performance improvement related to your day-to-day activities. Coaching over time, or longitudinal coaching, is where we're actually looking at, establishing a relationship that has some continuity to it, where we can actually respond to performance patterns and be able to actually reflect on performance to help sort of facilitate, ongoing goal setting. And so it's actually longitudinal coaching that I find the most interesting. And I should mention that I was part of sort of the leading of a design and implementation of a longitudinal coaching program for our pediatric trainees. And so that's actually where I feel like coaching coming into medicine has the most promising sort of impact. So what is a coach? And I will say that, while there were all of these frameworks for a while, I still didn't really have a good appreciation for the how to. How did we actually expect people to coach? What did the role really entail? And what skills was it that we needed our coaches to have and our coachees to have? And so I ask you guys, how much do you agree or disagree with this statement? The definition of a coach as it applies to healthcare professions is clear to me. Do you strongly agree, strongly disagree, or somewhere in between? And so you should see a poll sort of come up on your screen. I'll give like 10 more seconds and then I'll share the results. Okay, so we have actually a really nice split. So sort of the majority agrees, but not by much. So I think we have a really nice split of different people. And like I said, I've spent a lot of time trying to understand what this role is. And certainly in this design of the program, it actually took me a lot of time to figure out exactly what skills I wanted both parties to come to and what our goals for the program were. And so I think this is the area where we really want to see more literature and research coming out. Okay. So when you do look at the literature, I actually do think we have a pretty clear sort of philosophical impression of what coaching is when we think about it within the realm of medicine. So I've pulled three different definitions just so you can see that there is actually a lot of clarity as to what people sort of expect coaching to be. So in this paper where they actually looked at, all of the different roles and relationships in medical education, they actually talked about this idea that a coach is someone who strives to extract the highest level of performance from the learner. Similarly, in this paper by Landreville, where they actually tried to define coaching in medical education, they talked about coaching as a process. It's a process that guides the learner towards performance improvement. And so just by sharing those two quotes there, you can see that the outcome of coaching is very clearly about this idea of ongoing growth and development. This quote comes from a paper where they actually were summarizing the findings from Chris Watling's paper. And I like this one because it has multiple elements to it. So here they talk about, coaching carries this connotation of mutual engagement and partnership, of dedication to growth of an individual, and of embracing vulnerability and teaching the learner to fail well. And we'll talk a little more about this vulnerability and failing well piece, because I think this is a really important thing for us to acknowledge if we want coaching to be successful, but recognizing medicine's professional culture. And so another poll for you. So when we actually did a needs assessment with our faculty, the biggest area of need was some clarity around what all the different roles were within medicine. And the ones that tended to be most mistaken was actually trying to figure out the difference between coaching and mentorship. And so I ask you to think about this statement here and let me know what you feel. You either agree, disagree, or somewhere in between. So this should pop up again on your screen. Couple more seconds. Perfect. So again, we have a nice split here. So no one strongly disagrees. So there's definitely been some, education and some clarity there, but still there's quite a few people that kind of don't have a great sort of sense of the clarity between these two roles. And I think that's appropriate because I think there is actually still some work to be done to understand that. And so I think this is one of the things that we need to consider as we think about implementing successful coaching programs, is really making sure that we're thinking about, we're already asking faculty to hold so many different roles. And so if we're going to bring in another relationship or another role, we need to make sure that it's not redundant, that it's different than what we have, and that it's actually filling a gap that was there previously. And so when we were thinking about our longitudinal coaching program, we took about 8 months to actually get that prepared before we implemented it. And there was two major questions that we had to answer before we would even put in the effort to actually design the program. And one of the questions was, was coaching going to add something that was different than what we had, right? We didn't want to waste our faculty's time by asking them to add another role. And we certainly didn't want our residents thinking that they were just simply showing up for another checklist meeting. And so that actually facilitated a lot of thought and a lot of engagement with our resident group as well about understanding how we could actually fill a gap that we previously identified was there. And I would say, mentorship, coaching, probably the two that are thought of most interchangeably. Teacher as well, sort of a common role. And when we talked to our faculty, we did actually admit that, while you're in a coaching relationship, you may find that at times you might be providing some mentorship. But the key is that, if you're finding that your whole sort of conversation is geared towards mentorship and you're not actually meeting the outcomes of your coaching relationship, then that's sort of when you realize that we're probably not meeting the goals of the program. I thought this was a really interesting diagram that comes from the AMA coaching guide. And here what they highlight is this idea of who is the expert in the relationship. So what you can see on the left is that in a coaching relationship, it's actually the learner who's the expert. They're the one with all of the information about their performance. They're the ones that have the reflection. What the coach's job is really to help provoke that reflective dialogue, help co-create goals, facilitate some conversation. But a lot of that data and information sits within the learner. In a mentorship relationship, you want your mentor to be the expert. They're the ones that have the expertise, they have the personal and lived experiences to actually be able to provide advice and guidance. And so that's a little bit different than the nature of sort of the coaching relationship and the mentorship relationship. This chart I thought was kind of nice, and this comes from Lowell's systematic review where he looked at literature of coaching in medicine. And I draw you to sort of three main areas that he tried to sort of differentiate. So when he thought about sort of the goal of the mentorship relationship and the coaching relationship, in mentorship, it's very much about advice and guidance. In a coaching relationship, it's very much focused on this idea of identification of specific areas for improvement. When you look at the techniques and approaches, again, with mentorship, very focused on advice and guidance, and it's more of a discussion-based conversation. In coaching, one of the biggest things about coaching is this idea of being able to encourage and elicit critical self-reflection. And it's a really collaborative relationship. In the definition earlier, we heard about this mutual engagement and this partnership. When we look at the purpose of the relationship, in mentoring, what you're really trying to do is, inspire some motivation and provide some advice on how to sort of navigate something. And you're often using your own personal or lived experiences to be able to provide that expertise. When we look at coaching, the purpose that we're actually looking for is to try to constantly sort of push the learner to want to continue to improve and helping them sort of with that mindset of ongoing growth and development. In this paper by Stoddard, what they did was they looked at, okay, what are all the different labels of relationships that we know that currently exist in medical education? First, they separated them by whether the person had to be intra-professional or whether they could be extra-professional. Then they looked at 4 different educational purposes. And you can see that coach actually ended up in the relationship building purpose. But what the authors actually talk about in the article is that probably coaching would have fit under all 4 educational purposes. But it's the key to the relationship is that without it, you can't actually get to the outcome. And so because of that, they felt that it best fit under relationship building. And what I find most interesting, and I don't think most of us have adopted this, is that they actually claim that a coach can be extra professional. They don't necessarily need to be within the specialty or the discipline. And so I think that, offers a really unique opportunity for us to think about expanding our coaching pool. And I would say from talking to other programs sort of across the country, not many are doing this yet, but it is something we've been trying to sort of implement as we start to roll out our program. So what do we know about medical education? So certainly the literature is growing quite a bit. And I always sort of talk about, one of the first big papers, which was Lowell's systematic review in 2018. And what I find interesting about that is at that time, he had about 21 papers that he included in his review. And there was no actual coaching interventions that were documented prior to 2008. So it's still a fairly new and novel concept that at least is being described in the literature. In those papers, there was 3 main themes where coaching was used. There was coaching for doctor well-being, there was coaching for non-technical skill acquisition, and then there was coaching for technical skills, such as mostly predominantly was surgical skills. And what they found was there's actually good data for decreasing surgical errors, increasing technical skill acquisition, improving exam scores, and identifying learners that were potentially going to struggle or needed more attention. They didn't have much in the way of, how coaching actually impacts patient care. Mind you, decreased surgical errors would obviously definitely benefit our patients. And the other thing was that while they did describe coaching interventions and programs that had, positive impacts, there still wasn't much to actually describe what was it that the coaches were doing. What were the skills that they had? How are they actually operationalizing the relationship? And a lot of these studies, had funding to support these coaching models that may or may not actually be possible outside of sort of having that grant to run that study. And so that's an interesting thing for us to consider as well. This was a newer paper that I think actually brought up some really interesting things for us to consider. So this is the idea of perhaps coaching can actually help us with professional identity formation. And in this paper, they actually illustrate that there's quite a bit of tension between our idea of competency assessment and our, the way we've been pushing our learners to have a growth mindset. And that perhaps, our culture of medicine and the way we're sort of running a lot of our assessments may not actually be allowing our learners to be vulnerable and to adopt a growth mindset. And so I found that to be quite interesting. What they did talk about, though, is that coaching relationships show a ton of potential for this opportunity to actually be able to form professional identity. And the reason being is because it actually provides a safe space where they actually can engage and reflect on these tensions and help sort of sort out, how does their personal identity, their professional identity, and their professional commitments potentially, interfere or interact with one another. And that's actually an opportunity to sit down and talk about that in a space that's safe without assessment. This, I think, is really interesting. So Dr. Jessica Rich at our Royal College webinar talked about this idea. Our coach is actually the MVP or the most valuable player of CVME. Right now, we have learners who are obtaining tons of data, and we have Competency Committee who's taking that data and making a decision. But a lot of people would argue that there's actually this white space between the learner and their data and Competency Committee's decision. And it would be a shame. I think it's a shame if, with all of these EPAs, we know that EPAs have brought a burden to both our faculty and to our residents. But the benefit of all of this information is that it actually allows learners to digest it and actually be able to inform sort of ongoing goals. But if they don't actually have a space to sit down and actually have some protected time to think through all of these evaluations, look for themes, kind of help it modify their goals, then we could actually be missing out on the benefit that we intended with all of this extra information. The other piece is to think about, what is the relationship between coaches and Competency Committee? And we thought about this a lot when we were talking about our longitudinal program, because what we actually found is that unanimously, both residents and Competency Committee said we want our coaches actually to be that bridge between our learners and between Competency Committee decisions. And so I think coaches from that perspective bring a lot of opportunity for helping us to fill this space that was there before. And so I think that's something that coaching is very promising to offer to us in the CVME model. And so those are kind of the areas that we see coaching to have some potential within medical education. And I want to transition to this idea of coaching and feedback. And I think sometimes this brings up, a lot of unnecessary confusion in a lot of ways. And I remember as a resident at the time where it was still sort of being explored, is I'd have learners say, thank you for the feedback. And another learner would say, thank you for the coaching. And I would reflect on that and think, I don't know that I did anything different from this learner to this learner, but that was sort of their impression. And so I thought a lot about, what is actually the difference between coaching and feedback? Is coaching simply just a new framework where we've put in a term to describe effective feedback that perhaps some of us were already doing before? And so if you look at the Royal College, this comes from one of their slides in their slide deck on CBD for coaching. They've made it just a tiny bit more confusing for us, and they've actually just put the terms together. So they said, we're actually going to be doing coaching feedback. And, they did nicely actually distinguish it for us. So the idea being is feedback is sort of content. It's the information about, what was observed compared to some expected standard. Coaching feedback is this feedback, but it actually has some actionable suggestions for improvement, right? So to give feedback without actually having some suggestions or at least being able to co-create some goals moving forward, sometimes that can actually feel not as helpful to the learner. Dr. Atkinson actually just put out a print about feedback and coaching, and I think they did a really nice job of actually bringing some clarity to this idea. And what they talk about is, feedback is an educational tool. Again, it's this content, it's this dynamic conversation about sort of how someone performed compared to what their own expected standard of themselves is. Whereas coaching is more of an educational philosophy. And you can't coach without giving feedback, but there's other elements that are really important when you think about coaching, such as direct observation when we're talking about coaching in the moment, such as being able to elicit reflective dialogue, and also be able to help with targeted goal setting. So all of those would sort of be encompassed in this philosophy of coaching. Now, we've been giving feedback for ages. So why did we have to make this dramatic change? And so interestingly enough, now this was back in 1994, so this is a while ago, Irby said, well, feedback in medical education, it's an intractable problem. And a little more recent, in 2012, they actually looked at sort of learning from clinical experiences. And in there, they talked about the fact that participants recognize that constructive feedback was probably key to their medical training, but that actually the stories they shared suggested that truly influential feedback was unfortunately fairly uncommon. So what would former athletes and musicians say? So we go back to that study where they looked at medical trainees who had backgrounds as musicians and athletes. And what they had to say was sort of similar. A lot of feedback people get is that, of course, your knowledge is never as good as it can be. I think this is the classic read around your cases. That's a really vague thing. But saying to a musician, well, that was pretty good, but you could play a little bit better, that's essentially the equivalent, and obviously would be very dissatisfying to the musician. Another participant shared, if they tell you that you need to improve, but they can't actually tell you how, then it's useless information. And this one I thought was interesting. So they said, I think that feedback actually has a much smaller role in how medicine is taught. I think in music, in that culture, feedback's so vital that it's not even called feedback. And I think that's interesting because while having elite athletes and elite musicians is important, having trainees who are excellent to be able to care for society and care for patients is also really important. So if we recognize that influential feedback is so important to the development of our trainees, then it's definitely an area that we need to prioritize to make sure that we're using it to benefit our trainees the way that we should. This quote really resonated for me. This also comes from that same study. And one of the participants actually said, you expect your coach to criticize everything you do, because if they aren't, that means they aren't watching. And this definitely, as someone who started playing competitive sports at an early age, I was very much socialized to expect that if the coach was not yelling at me or finding something I was doing wrong, then I actually had to worry because it means that they didn't see any potential in me. And so if I wasn't getting criticized all the time, it actually meant that they lost hope in me, or it was actually a very negative thing. You're starving for constructive feedback because it means that they actually see potential in you. I don't know that we're quite there yet in medicine. When I joined medicine, this is someone who came into it with that attitude. I think I got resocialized. I almost realized that what I actually wanted to be looking for was a pat on the back or someone to tell me that I was meeting expectations, as opposed to sort of wanting and starving for this constructive feedback on how to continue to get better. And so my question for you is, are we at a point where we think that our mindset of our learners is similar to this? So do you think that this quote is the mindset of our learners in medical education, that they're keen to receive constructive feedback? So I'd like to get your thoughts on that. So we have a pretty big split, which is interesting. So I think it's promising to see that we definitely think that there's some people who strongly agree with that statement and agree, and others that disagree or strongly disagree. And I don't think this has anything to do with our learners. I think our learners are actually looking for this sort of information. I think the problem is that sometimes our actions as educators, or just our actions just in the clinical environment, may actually be sending unintended messages that perhaps what we want is for people to already be competent and to already know what they're doing. And so I think that makes that difficult. So this is a nice chart that comes from Adele's paper about, conditions for effective feedback. And while I'm not going to go through everything, I like to actually draw attention to this idea of credibility, because I think credibility of feedback is a really interesting concept. When there was a paper that was done with internal medicine residents, when they looked at, what does actually sender credibility mean? What I was struck by is the fact that they actually sort of concluded that residents would often discount feedback if it came from somebody who had a low level of knowledge that they perceived or had less experience as a physician. And why I find that so interesting is that, someone's ability to give feedback, so to observe and be able to give some actionable suggestions, probably doesn't have much to do with their performance as a clinician, but very much the learners in this study, and this has been shown in other studies, sort of judge the person's ability to coach or to give feedback based off their performance as a clinician. And I think we do this a lot in medicine. You're a good teacher, so you'll be good at this and you'll be good at that. You're a good clinician, you'll be good as a leader, you'll be good at that sort of thing. And conversely, in the study where basically they looked at all different people that had roles within coaching, so no learners involved, they actually identified that for someone to be a good coach, it actually had less to do with their own knowledge and skill as a clinician and more about their actual ability to bring out the best in their learners. And we know, if we look at the sporting sort of world, is that the best coaches were often not very good athletes, and vice versa. Some of the best athletes are terrible coaches. And the reason for that is it's very different to be a player and to be a coach. And so this idea of credibility, I think, does need to shift a little bit, because I think to develop skill sets as a coach is very different than actually our skills as a clinician. And so with that, I'm going to transition to this idea of, is it fair for us to compare coaching in sports to coaching in medicine? There was a really great paper, probably one of my favorite papers, that was done by Chris Watling. And what they did is they actually had 21 different participants, so 3 main groups. 6 participants were university varsity coaches, had nothing to do with medicine. 10 of them were actually people who were clinician teachers, but also had roles as coaches outside of medicine. And then the other 8 were clinician teachers with no experience as coaches. And they interviewed all of them, and they asked them to sort of reflect on their roles as coaches, to understand what their motivation was, to talk a little bit about their philosophy, and to reflect on times where they were successful as a coach and sort of understand what was it that made them successful. And what they found is that there was 3 shared philosophies amongst all the participants. That coaching was about this idea of mutual orientation towards growth and development. And we've heard that earlier before as well. This idea that endorsement of reflection. So reflection is really important part of a coaching relationship. And this key element, which is that to embrace failure is to recognize it as an opportunity for learning. But while there was shared philosophies amongst all the participants, there were some distinct cultural differences between medicine's culture that we needed to keep in mind. The first one was this idea of engaging in reflections as a coach. So our varsity coaches talked a lot about their reflection on their experiences, whereas our clinician coaches actually didn't really talk much, and that's probably because they have so many other things that they're constantly doing. This idea with comfort with vulnerability. It's very easy for athletes to feel vulnerable in a lot of ways, but it's very difficult for our learners to feel vulnerable given the stakes of patient care. This idea of blurred lines. A hockey coach can't jump onto the ice and become a player. At any time, a faculty coach can jump in and become the player. And that actually makes things quite different as well. And this idea of defining and developing coaches. So most of the time, elite coaches, it's their full-time job. It's all they're doing. Their job success is dependent on the learner's success. And because of that, they have lots of time to sort of develop their skills and commit themselves to being better. In medicine, coaches are people who have all these other jobs at the same time. And so finding that time and that opportunity to actually develop those skills can sometimes be very hard to do. And so what now? So as we move to coaching, and even the Royal College says that not only will faculty now be clinical teachers, they will be coaches. My question is, how ready are we for this? And so I'm going to ask, those that are here today, sort of how ready do you feel and how much experience do you have with being coached on your clinical performance? I find that a lot of people are more comfortable with being coached in non-medical expert ways, right? As on their leadership or maybe in their roles as teachers, but actually being coached within the clinical capacity. Okay, so, no one really has lots of experience, which is fair, but we have sort of a spread of people from some experience to no experience, which is interesting. And I think it's interesting because, when I lived in Ottawa, I lived in a basement apartment of a lovely family, and, they had a 6-year-old who wanted to play some coach pitch. And so, I thought about, if I wanted to coach as a former Olympian in the sport, if I wanted to coach this 6-year-old playing recreational t-ball or coach pitch on the weekends, what would I actually have to do? And so if I go on the website, you can pick the sport and then you can pick whether it's competitive or community. And so even if I, as someone who's done lots with the sport, wanted to coach on the weekends for 6-year-olds, I'd actually have to go through 2 different credential training. So those would include coach workshops and different types of development to be able to coach a 6-year-old in a sport that I played for most of my life. And so I think that's really interesting because it just shows that there's so much to the role of a coach. Just because I was a good athlete doesn't actually mean that I'm going to be ready to actually help and coach, other kids. And when you think about these coaching programs and you think about developing faculty, don't forget about the learners, because I think one of the most important things that we have to promote is that a coaching relationship is actually a proactive responsibility of both parties. So to only develop faculty and have the learner sort of show up and sort of by osmosis get the most out of that relationship actually won't lead to successful sort of relationships. What we need is actually to dedicate as much resources to developing our trainees about what their role is as a coachee as we do to actually developing our coaches. And so when we did our longitudinal program, we actually, for every material that we built for faculty, we mirrored that for our trainees. And we also did as much training for our coachees as we did for our coaches, with this expectation that both of them sign a coaching contract and they come to those meetings with actually making sure that they bring their skills, they keep working on their skills so that they can get the most out of this partnership. Here's some of the examples of some of the materials that we had developed. And you can see here that, we had both a faculty coaching guide, but also a coachee guide. We had a module that actually both faculty and residents could access. And then our workshops were actually geared towards building the skills that we thought were important for coaches in one of them, and then the skills that we identified as important for our coachees in the other. And so what did we actually decide those skills were? And this may be slightly different depending on, how your institution adopts coaching. But for us, we really wanted our coaches to understand how to establish an educational alliance. We wanted them to know how to facilitate targeted goal setting using the SMART goal framework. They needed to be able to provoke reflective dialogue. And so we supported the R2C2 framework. And then they needed to be able to interpret learners' CBME data. There's so much data that, to not be exposed to that previously, it can be overwhelming. For our coachees, we wanted to teach them actually how to create SMART goals, how to engage in reflective practice. And so we taught them Gibbs reflective cycle, but recognize that there's lots of other opportunities to learn how to reflect. And then we really wanted to help them foster and adopt a growth mindset. And so with those skills in mind, that was sort of how we target a lot of our development. So while I didn't talk a lot about, coaching in the moment, I just wanted to bring to your attention that there is actually some modules on the Royal College website about this RXOCR framework. And so this is the framework that they sort of suggest that we should be using as faculty when we're actually talking about doing coaching in the moment. And so I just wanted to share that with you, and you can get Section 3 credits for actually completing that. If you're someone who likes podcasts and you like them digestible in like 20 minutes or so, there's actually a nice podcast that's done by colleagues at Western. They currently have 6 episodes and we've just recorded a few more. And so if that's something that you're interested in, just to hear other people sort of brainstorm some of these challenging topics and sort of acknowledge some of the barriers that we're up against, it's often a nice, interesting conversation to sit in on. And, as we think about future considerations, some of the things that I think a lot about is, how do we make sure that the return on investment is there? And so we're going to be doing a study in about a year to really understand at the end of this, do our learners and our trainees actually have the support systems that we intend with all the different roles in our program? Are they redundant? Were they already getting that support? And perhaps this is just an extra sort of burden for both parties. I also think it's important for us to recognize that as we graduate these trainees who are so used to coaching, that we probably should think about how coaching can be beneficial for faculty. As someone who is now a faculty, I often think a lot about the performance plateau, and I don't want to get there, right? And so I want to actually be able to be supported to continue that. And I think as we think about our learners who are going to be adopting this growth mindset, we have to think about how to support them as they transition into practice. The other thing I think we have to think a lot about is how the culture of medicine isn't necessarily set up to adopt a lot of these education or these coaching philosophies. And so as, faculty, how are we role modeling vulnerability? If we're asking our trainees to be vulnerable, what is it that we're doing to showing them that we're actually also willing to be vulnerable as well? The other idea is, how are we constantly striving to, be coached and to get better? How are we asking for feedback from our learners, and how are we sort of reacting to that when they do share it with us? So some things for us to consider as we continue to progress with coaching in medicine. And so I challenge you guys today. So, my thought is, let's not just coach to competency. Let's actually think about coaching to personal best. And with that, I think that is it.
Thanks very much, Robin. I think it gives us a tremendous amount to think about as we develop our CBME program here here in the Department of Pediatrics. So I think I'll open it up to questions. There was a number of things in the chat that people raised around the concept of this giving of feedback that may not always be positive, linked to the concept of growth mindset, and how maybe this, as you mentioned, is not our culture. And I wonder, maybe I'll ask Chris and Heather, who had both put stuff in the chat, maybe to expand.
Sure, I'm happy to talk. I'm sensitive to having had some learners in difficulty over the years who trying to provide feedback is always tricky. And when a learner is feeling sensitive and vulnerable, having someone who is in authority provide feedback at all can be quite intimidating. So when you were talking about the notion of, a coach finding everything you've done wrong, that attitude worries me. It kind of harkens back to the days when, on rounds, someone would get picked on. So I know that that is not what you're saying, but I'm finding it hard to navigate how to apply coaching that is not, it is identification of weaknesses, but it's how to do that safely.
Absolutely. I think that's the key thing that we have to think a lot about. I don't know that it's always actually about identifying weaknesses. I think it's actually sometimes, I think we often think it's negative. We often think constructive feedback is negative. A lot of people say, oh, I have nothing negative to say. And it's like, no, I didn't ask for anything negative. I asked for something constructive. And so sometimes that can be, the learner might be performing, like I said, at a level 5. they might already be doing it. But what I always tell my learners is that I owe you, if there's one way I can give back to you as someone who's a general pediatrician on the ward, you guys do so much for me. The one thing that I can give back to you is hopefully an opportunity to find an area to grow, or at least, a tip to be able to sort of strive for ongoing growth and development, because you're in training, right? And so I think sometimes it's even about, if you did something really well, what is it specifically that you did well so that you can continue to do it, right? And what is sort of that next opportunity to kind of continue to expand on that, or to look, beyond the level 3, or what's up beyond the level 4. And so I think, this even is just that challenge. If you're going to fill out an EPA and you're going to give a level 2 or 3, you can't not give them some sort of actionable suggestion or next step. And so the idea is not to sort of break apart every performance and tell them that there's always something they did wrong. But the idea is to sort of promote this idea that you're going to give to them an opportunity to sort of still see that there's room for growth and room for potential. And sort of that's the way I tend to try to frame it. But you're also right. I think you bring up a really interesting point about the learners who are struggling. And so they are extra sensitive to that information. And that's where I think coaches can be really interesting as well, because they can take a step away, right? So it's not necessarily the program director giving that information or someone in that sort of spot. It's actually someone who feels a bit protected and removed that can actually help with having the opportunity to digest some of that, right? So I had a learner who had an eval that she couldn't even look at it for a while. And it took us 3 or 4 meetings to get to a point where we could digest that and say, okay, this maybe wasn't written in the best way possible, but here's what we can actually take from this. But that took 3 meetings, and I wasn't the person who was a program director. I wasn't a competency committee member making a promotion decision. I wasn't the person that filled out the eval. And so sometimes I think it just allows them to have a safe space to really be able to digest some of that info and be able to get there.
Manuela, I see your hand up.
Hi, I thought there was someone before me. You asked Chris and somebody else.
Oh, it was me. I just don't have a camera on. That's what I was going to say. I'll just quickly make a comment. Yeah. Robin, thank you very much. Very thought-provoking, actually. And I'll say in honesty, I'm going to go look up some of your references, because I'm not sure I have 100% grasp on the difference between coach and mentor, or how their roles are a bit different there. And I think what Anna wants me to mention has to do with that trophy culture, perhaps, of younger people. And I'll put something also in context, I guess, about coaching, because I had been a competitive tennis player coach, and my 2 children are high performance athletes. And I think that children sometimes suffer when they don't get that piece of positive feedback too. Like, so I took a picture of your slide that said that as a competitive athlete, you expect your coach to be negative, right? And if it's not, they don't care about you almost, or to give you some feedback. Similarly to medical students and residents, I don't think every child responds to that. I think people still need a nugget of positive encouragement too. But the comment in the chat that I mentioned was that era of every child gets a trophy, no matter how well they do, has been that people are overpraised, in a situation that I think we're coming on the other end of, because everyone's recognizing that it was maybe more damaging to young adults than not, was that we had top of the high school class, right, to get into university, and then maybe we had top 5% of university students get into medical school, and then if you continue to shift the bell curve, everybody in medical school can't be the top 5% or top 10% of medical school. So in pediatrics, I know I can't speak for everybody on the call, but I think some people would agree that we might have been the first people on wards or in clinics or on the rotations to give less than stellar feedback to students, because in their lives they had always been champions and they had always been at the top. And sometimes that was even, I would say, the most gentlest delivery of that, right? I would never give negative or constructive feedback without solution or without some aspect of positivity. And no matter, as you were saying, with the learner that couldn't see their negative evaluation, sometimes it was really just met harshly. So I don't know whether or not there's much information about coming out on the other end of that, but it's certainly talked about more. And I don't always like to just lump it into intergenerational differences, right? Like I think we're all sort of working together in the workplace.
Thanks.
Absolutely. Yeah, agree.
Emanuela?
Okay, my turn. Thank you so much, Dr. Mackin, for this wonderful presentation. I have one comment. When I meet with the undergrad students right now, I talk to them about extra professional coaching because I had it. And I found that is absolutely deeper than, and opens their mind even to what they want to do. Not only, and for me, as I put in the comment, helped me to be who I am and understand who I was, okay, and what I want, more than which kind of doctor I wanted to be. So much deeper level. Probably it's cultural because I'm European and we are really, really, striking that during medical school, if we do many, many mistakes, but, the part of who you are, it's absolutely mandatory. And what I found striking is that they are very surprised when I talk about extra professional coaching, and I wanted to have your comment on that. The second question that I had for you is that lately some of us had taken a new role as an academic advisor. Again, I find this for the EPAs and the new model, right, on competencies. But what I found is that, again, it's a vague dilution when I face the reality of meeting with my trainee as an academic advisor, counting the EPAs, but I realize that it's not only that. Definitely is not only that. And it depends where my trainee is, if he's performing again kind of okay, thriving with the new residency or fellowship in particular. I meet a lot of fellows, and I am again, okay, so academic advisor as this according to the Royal College, right? But in reality is not. And so what is your take on that? Thanks.
No problem. So your first one about extra professional coaching
Yes.
is really interesting. I think that there's a lot of opportunity for that. I think about being a team sport and how our head coach was not the only coach. We had a pitching coach, an outfield coach, an infield coach, a hitting coach, because one person can't do it all. And so I think, as opposed to looking at discipline specific coaching, we're probably looking at skill set. I'm maybe good at coaching about communication, but I might not be as good about coaching for technical skills. And so that might not be as discipline specific as it is just expertise from that perspective. The question about the academic advisor piece is, it's interesting. I think advisor and coaching, it depends on your institution on how it's developed, but essentially a lot of places have called advisors and they're employing coaching philosophies, which is fantastic. I think that, with those relationships, what we've really been telling our coaches, which is a very similar thing, is that it's actually, a lot of it is about provoking reflective dialogue. Is a lot of that meeting is about reflection and actually co-creating goals. So while you use that data, you go through that data, you digest it, a lot of that time together is actually about, reflecting on that information and being able to modify and keep changing learning plans, right? And so one of my biggest pet peeves was when learning plans were prescribed for not doing well, when in fact every learner needs to start with a learning plan and they kind of, adopt and change things as we go. So that's a short answer. I'm happy to sort of share some of the stuff that we're using for our coaches, which would be advisors, after this, if you'd like.
Absolutely. Thank you so much.
That's great. Toby, I see your hand up. Where it's 9:31. I don't know if it's a longer question or a quick one.
It's okay, I can pass.
Or I think Robin provided her email. Can always email for extra support or information. So with that, I'd like to bring Grand Rounds to a close. Thank you so much, Robin, for coming and sharing your expertise. A lot of very, very valuable pearls. And we actually look forward to working with you for our workshop